Hey everyone, today we are going to study about acute cholangitis or ascending cholangitis. So, what is the pathogenesis behind this condition? It is simply bacterial infection of the biliary tree. And this infection is due to two reasons. The first is biliary obstruction, and the second one is biliary stasis. Now, the biliary stasis or obstruction further happens because of mainly two clinical conditions, namely cholangitis and biliary stricture. So, what do you mean by cholangitis? It is defined as gallstones which block the biliary tree somewhere, block or obstruct the biliary tree. Whereas biliary strictures are defined as narrowing of the biliary tree in certain places. This would be a stricture. It's a narrowing. So before we move further, it is important that you are well versed in the anatomy of the biliary tree. So the biliary tree consists of the gallbladder, and the gallbladder has a duct called the cystic duct. The cystic duct joins the right and left hepatic duct, forming the common bile duct. Now, this common bile duct further goes down and joins the pancreatic duct at the ampulla of Vater, and then this flows into the duodenum. So here you'll have the liver, here you'll have the pancreas, and here you'll have the second part of the duodenum, where this is your ampulla of Vater. And here you'll have a sphincter called the sphincter of Oddi. This is the common bile duct. These are the right and left hepatic duct. And this is the cystic duct. Well, this is your gallbladder, liver, duodenum, and the pancreas. So, whenever there is some kind of gallstone which is present in this region and then it goes and obstructs the cystic duct, it leads to inflammation of the biliary tree because of stasis of bile, which is called cholangitis. There are some other causes which lead to biliary stricture, like infectious or autoimmune causes or trauma. It can even be iatrogenic when the doctor is performing an MRCP, for example, which can lead to biliary stricture, where this biliary tract becomes narrow, and then that also leads to bile stasis. So that's about the pathogenesis of acute cholangitis. Now, next we will learn about how you present when you are suffering from acute cholangitis. Now there is a triad and then there is a pentad, which are two things that you need to keep in mind when you're thinking of acute cholangitis: triad and pentad. The triad is defined as the Charcot's triad, which happens in mild disease, whereas the pentad is Reynolds pentad, which happens in severe disease. Okay, so we can divide our page into two parts. So first, talking about Charcot's triad. So person who has early acute cholangitis will present with abdominal pain, fever, jaundice. You'll see icterus. The fever is usually high. The abdominal pain is usually where the gallbladder is present, that is the right upper quadrant. And this happens in 25 to 70% patients. If a patient does not present with this triad, then we have to rely more on investigation for the diagnosis if it's a very vague presentation. However, when the disease becomes severe, apart from these three, that is abdominal pain, right upper quadrant, fever, and jaundice, you also have two more symptoms. Let's use a different color for that, namely hypertension and mental status changes. So your patient can present with altered mental status. And this hypertension is because the patient now is going into shock, which will actually be a type of septic shock because the patient has widespread infection now, which was earlier limited only to the biliary tree. And this becomes an emergency situation. If the Raynaud's pentad is seen, then you know that the disease has progressed and you need to take emergency action. So in this stage, the patient can have the following complications. He can get sepsis, septic shock, and if it becomes even more severe, this mere acute cholangitis can lead to MODS, or multi-organ dysfunction syndrome, multi-organ damage syndrome. Alright, so I have a mnemonic for remembering the Raynaud's pentad, sorry. It's for all the people who love Office. There were two pivotal characters in Office, namely Pam and Jim, and their last name was Halpert. So my mnemonic is Pam, Jim, Halpert, in which we will take into account P-A-M, J from Jim, and H from Albert. That is 5 letters. The P stands for pyrexia or fever. The A stands for abdominal pain. The M stands for mental status changes. The J stands for jaundice. The H stands for hypertension. So this is how you can remember the Reynolds pentad. Now we next move to the causes of acute cholangitis and also the diagnostics. So what are the main causes of acute cholangitis? We already know that it is caused by biliary duct obstruction. The second thing that comes into mind is what are the causes? As we learned, the first is cholangitis, then biliary strictures, which are due to primary sclerosing cholangitis. For example, the third is malignancy. You can have cancer, gallbladder cancer, which spreads up to there, or you can have pancreatic cancer. Malignancy leading to obstruction. Then extrinsic compression, as seen in Murray syndrome. Then parasitic infections from the liver, like liver fluke, hydatid cyst, and ascaris. Acute pancreatitis, contamination of bile with intestinal contents. This is important because bile is usually sterile, thinner, and last is iatrogenic, which may happen during instrumentation like ERCP, papillotomy. All this instrumentation may further lead to acute cholangitis. Okay, so we have covered the pathogenesis, the anatomy, the presentation, and the causes. Now we come to diagnosis, and then we will talk about treatment. Now the diagnosis is done according to the 2018 Tokyo guidelines. It's according to the 2018 Tokyo guidelines, and it divides the diagnostic criteria into three. The first one is systemic signs of inflammation, like diagnosis. Let's see, this is the color of ink. Fever, chills, increased double BC count, increased CRP, ESR, markers of inflammation. Then second is signs of cholestasis. Like jaundice, LFTs, AST, ALT are mildly raised. Okay. Alkaline phosphatase is increased, gamma glutamyl transferase is increased because the biliary tree is involved. When the biliary tree gets inflamed, these are the markers to look for. Bilirubin is also raised. Why? Because there is jaundice. So all these point towards what? They point towards cholestasis. And the third and the last one is imaging. What are you looking for in imaging? You're looking for biliary duct dilation or any evidence of underlying cause. You know, like what sort of evidence are you looking for here? Cause you need to look for evidence of cholelithiasis, or it can be an evidence of primary sclerosing cholangitis, or it can be an evidence of malignancy. So any kind of imaging which helps rule out these kind of underlying causes helps to diagnose acute cholangitis. So once this is done, this thing is further divided into a suspected and a confirmed diagnosis. So you can have a suspected diagnosis, acute cholangitis or ascending cholangitis, or you can have confirmed / definitive diagnosis of acute cholangitis or ascending cholangitis. Okay, so when suspected diagnosis is more than one sign of inflammation plus more than one sign of cholestasis, or the word or is important, more than one or equal to one signs in imaging. So this will be a suspected diagnosis. However, when this or becomes plus, it's a definitive diagnosis. So more than one signs of inflammation, more than or equal to one signs of inflammation, plus more than equal to one signs of cholestasis, plus more than or equal to one signs in imaging. Pay attention to the plus here and the or here. Sorry. The or here. So here it's this for sure, and this or this. Here it's this, this, and this. All three need to be present. That is why it's definitive diagnosis. So this finishes off the diagnostic criteria, but you still need to know a little more about the complication. So very important complication that can be seen with acute cholangitis is anion gap metabolic acidosis, and this may be presented to you in the clinical vignette. That's why it's important. What happens in an anion gap metabolic acidosis? Due to lactic acidosis from severe sepsis. Always remember that sepsis will cause the lactic acid to go up, and that will lead to acidosis. But this acidosis will be an anion gap metabolic acidosis. Next is, what kind of imaging do we use when we are trying to diagnose acute cholangitis? Your answer is, you either do a right upper quadrant USG or a CT scan with IV contrast, or MRI abdomen with and without IV contrast with MRCP. So these are the imaging modalities. Now let's understand the imaging modalities a bit. Okay. First is USG. What do you do in this and what do you find out? This is more like the first line imaging. It's not the confirmatory imaging. You try to evaluate for biliary obstruction that may have led to precipitation of the cholangitis. In right upper quadrant ultrasonography, you will see dilated bile ducts, dilated walls, or cholangitis, biliary tumor, stricture. All this can be seen in the USG. Then the CT scan is done as a confirmatory test if USG is inconclusive. Here you will see concentric thickening and enhancement of the walls of the biliary tree because of the infection. Again, biliary duct dilatation, periductal edema, cholangitis, biliary tumor, biliary enteric fistula, which can cause the intestinal bacteria from the intestine to enter the bile, a parasite, portal vein thrombosis. All that can be seen by CT scan. Then the MRI abdomen with MRCP, which is magnetic resonance cholangiopancreatography. It is usually done if CT cannot be done. So you can either do this or this. Okay. So we normally prefer CT scan. It normally is the confirmatory test if CT doesn't yield results. So just remember this as the confirmatory test. Alright, so that finishes off imaging. Now we come to the most interesting part. Why interesting? Because that's what you'll be doing as a doctor, dude, which is treatment. How do you treat acute cholangitis? Now the treatment has two parts and they both depend on the basis of the severity of the disease. First is empiric antibiotic therapy, in which broad spectrum antibiotics are given and they have to be given ASAP, remember. The second is urgent biliary drainage. This is important because the bile is stuck over there, there is stasis. Unless you drain it, the infection will keep increasing, and then plus you have to treat the underlying cause. So the ascending cholangitis is because of some other underlying cause, so you need to treat that too. So the more serious the disease, the earlier the biliary drainage needs to be done. So what are the procedures that are performed here? What procedures are used in treatment? So the procedures that are used is first therapeutic ERCP, guided transpapillary biliary drainage. What is ERCP? ERCP is endoscopic retrograde cholangiopancreatic echography, and it's the preferred biliary drainage procedure in acute cholangitis, and this needs to be done in 24 to 48 hours. So how is this done? How is ERCP done, and how is ERCP guided transpapillary biliary drainage done? Now you have to understand that ERCP is a diagnostic and therapeutic procedure in which a side viewing endoscope is inserted into the duodenum and contrast is injected via the ampulla of Vater into the bile ducts. Different instruments are introduced via the endoscope to cannulate the common bile duct if needed. A sphincterectomy of ampulla of Vater or removal of gallstones from the common bile duct can also be performed. So that is ERCP. So it can be ERCP guided stone extraction or common bile duct stenting, or it can be papillotomy. Papillotomy is an endoscopic treatment with ERCP that widens the ampulla of Vater by cutting through the sphincter muscle, facilitates better passage of bile, pancreatic secretion, and possibly gallstones. So the urgent biliary drainage is done by ERCP plus papillotomy, or ERCP plus CBD stenting, or endoscopic ultrasound guided biliary drainage. This is the most preferred procedure, best one. The most preferred procedure is endoscopic retrograde cholangiopancreatic echography and transpapillary biliary drainage. So I'll show you diagrammatically how it's done so that you get a better idea. Now this is your gallbladder, this is your cystic duct, this is your proper hepatic duct, and this is your common bile duct, and this is your pancreatic duct. Here you form the ampulla of Vater, here you form the sphincter of Oddi, and like this you have the second part of duodenum, right? This is your story. This is the gallbladder, this is the cystic duct, this is the proper hepatic duct, then you have the common bile duct, then you have the pancreatic duct, you have the ampulla of Vater, and you have the sphincter of Oddi. I'll use a different color to show the instrument. So in ERCP, a side viewing endoscope is inserted from the esophagus, then it reaches the stomach, okay, like this, and then it reaches the duodenum and it reaches up till here. Side viewing endoscope is inserted, and then there is a contrast inside this endoscope which is injected into the biliary tree to make viewing it easier. And then after that, different instruments are introduced in this very endoscope. In this very scope that we have drawn here, different instruments can be inserted into it, and then with the help of that you can perform a sphincterectomy, or you can cut the sphincter muscle here and make it wider, make this hole wider. Let me use a different color to make it easier to understand. You are trying to make this hole, like the sphincter is like this, you are cutting it and opening it, okay? So this hole becomes wider now. It was like this, now it's like this. So when that happens, bile will pass, whatever bile is collected here, okay, everything that's collected here will pass easily into the duodenum. Pancreatic secretions that are stuck here will pass into the duodenum, and whatever gallstones are here, they will also pass into the duodenum, and then they will, here you have the jejunum, and then they will enter the stool and be excreted. So basically the bile stasis that is here, the bile will be drained. What are we trying to perform? We are trying to perform an emergency biliary drainage. So hence this is the best way to perform that. So once that is performed, we move on to our next priority, which is to treat the underlying cause. Treat underlying cause. For example, if there are strictures in the bile duct, we often go for common bile duct stenting, okay, in which a balloon stent is inserted. Hollow tube shaped frame is placed within a hollow viscus like the common bile duct in order to widen the stenosis of the lumen and support the walls of the viscus and prevent restenosis. Okay, so the bile duct is stenosed like this, and you insert a hollow structure like this. This will open the stenosis and then it will prevent restenosis. So when that happens, bile can easily pass through. Here bile is not able to pass through properly. Here bile can pass through properly, okay? And other than that, you can also do an endoscopic ultrasound guided biliary drainage, but percutaneous drainage, those procedures are not preferred when you have endoscopic procedures in the picture nowadays. So that's all about acute cholangitis. I will just do a quick recap of this so that it becomes easier for you. The quick recap is acute biliary cholangitis is caused by bacterial infection of the biliary tree. This infection is due to biliary obstruction or biliary stasis. Biliary obstruction can happen because of biliary stricture or because of stones there in the biliary tree, which are gallstones which trickle to the common bile duct, for example, called cholangitis. This is the anatomy of the biliary tree. The presentation is either a triad called the Charcot's triad or a pentad called the Reynolds pentad. The Reynolds pentad shows a more severe disease. It has the first 3 points of the triad, that is abdominal pain, fever, jaundice, along with hypertension and mental status changes. What are the causes of biliary stasis in acute cholangitis? They are cholangitis, strictures, cancer, malignancy, extrinsic compression, as happens in Mirzi syndrome, parasitic infection, acute pancreatitis, contamination of bile with intestinal contents, or it can be iatrogenic, done in the hospital, like ERCP or papillotomy. The diagnostic criteria are divided into 3 sections. The first is systemic signs of inflammation, the second is signs of cholestasis, and the third is imaging. So if inflammation and either cholestasis or imaging signs are present, Then it's suspected diagnosis if all three are present. Signs of inflammation, signs of cholestasis, and imaging evidence, then we confirm that it's a definitive diagnosis of ascending or acute cholangitis. An iron gap metabolic acidosis is due to lactic acidosis, and it's a major complication of ascending cholangitis. Now, imaging is by right upper quadrant USG, which is the first line because it's cheap, and if this is inconclusive, then you do a CT scan with IV contrast to confirm. Treatment, the first option is to give empiric antibodies, which are broad spectrum antibodies, even before you get a definitive bacteria which is affecting it. Why? Because otherwise it can lead to septic shock. So we are doing this to avoid the occurrence of an unfortunate incident like septic shock, which can kill the person. Then next you have to release the stasis. How do you release the stasis? If there is a blockage anywhere, how do you do that? You do that by increasing the diameter of the pipe, by making a hole. And then you also have to treat the underlying cause. So what are the procedures which are performed for biliary drainage? And it needs to be performed within 24 to 48 hours. The first procedure is, and the most commonly used procedure is, therapeutic ERCP guided transpapillary biliary drainage. In this, ERCP and papillotomy is done together. What do you do in that? It's a very amazing procedure and very high yield. So you basically insert your side viewing endoscope like this, and then it goes and inserts a dye into the biliary tree so that it can be seen. Then you insert an instrument in your endoscope and you cut the sphincter. The sphincter is like this and the bile cannot pass through. You cut it and you make it wider. So now whatever bile is there, bile and biliary sludge and even gallstones can pass through into the duodenum and can be excreted. And in this way you have performed an emergency biliary drainage. So this is your emergency biliary drainage. After this, you treat the underlying cause, like strictures can be treated by common bile duct stenting. You can treat the gallstones by surgery, by removing the gallbladder, and by drugs to prevent gallstones. So that's all about ascending cholangitis. The end. I hope this video helped you in some way. See you.